Hello, and thank you for joining our presentation today. I am pleased to review some general information about how to implement an allergy testing and treatment program into your practice. My name is Robert Erskine, and I'm the Director of Allergy for Innovation Compounding. My background includes over 20 years of academic and industry research in the field of immunology, followed by several years in scientific affairs with the world's largest allergenic extract manufacturer, a company called ALK. During my tenure at ALK, I worked directly with allergists and ENTs across North America and consulted on their allergy testing and immunotherapy protocols. For today's presentation, I will briefly review the workflow for allergy skin testing and immunotherapy, and I will describe how to best implement such a program into your practice. When I'm beginning to work with a medical practice for the first time, there are several questions I tend to ask before considering whether an ancillary allergy program is a good fit for the practice and how it can be best implemented. First, I want to know the type and size of the practice. While a large, high-volume clinic usually means that there are plenty of allergy patients to be found, it can also present some challenges, like coordinating the needs and concerns of all the providers or learning how to weave in a new type of workflow into an already busy clinic. Smaller clinics may be easier to navigate for implementation, but all too often there simply isn't enough allergy patients to sustain the program. Other questions include whether the practice accepts insurance, since the allergy procedures, from skin testing to mixing of treatment vials and administering shots, are all reimbursed through CPT codes. Also, does the practice have any previous experience with allergy testing or treatment? And how was that offered in the past? In many cases, I've had to go in and help practice unlearn some bad habits or bad clinical instruction. Finally, and possibly most critical, is whether the practice has someone who can dedicate time to learn and champion the program. Having a cheerleader in the office is often a critical success factor. So after determining that it makes sense to offer allergy services, the next consideration is how to best go about bringing in an allergy program. There are three general models for accomplishing this. First is to simply become an allergy specialist. This requires that the provider in charge become familiar with all of the clinical knowledge for allergy testing and immunotherapy. The clinic must also purchase all allergens and ancillary supplies, which can cost easily tens of thousands of dollars. Finally, you'll need to hire and or train someone in-house who can administer all the tests and prepare all the immunotherapy vials, following all of the current compounding regulations. On the flip side is a third-party service model. This requires signing a service contract with an outside company that will provide an allergy tech to come to your office and perform all of the patient interactions and procedures related to testing and treatment. These types of companies are set up to take the bulk share of insurance reimbursement. They also tend to create many headaches throughout the process and often leave the providers with big questions about the quality of care being offered to their patients. In the middle is a pharmacy-supported model. In this option, the practice partners with a reputable pharmacy that can compound all of the immunotherapy vials for the patients and also provide, or should provide, ancillary clinical support. The practice simply purchases testing supplies and immunotherapy, but retains full control of patient care and retains all of the reimbursement. Innovation Compounding offers a program called Allergy, a pharmacy-supported model where we train the practice on all clinical procedures related to allergy testing and immunotherapy, and we will compound the immunotherapy in our dedicated allergy mixing lab. Our program features an allergy skin test with a panel of 72 common inhalant allergens like pollen, pet dander, molds, and insects like cockroach and dust mites. We provide a variety of immunotherapy options based on the preference of the practice and the needs of the patient. Our clinical protocols closely follow the published practice guidelines from the allergy specialists, and we provide most of the forms and templates that are needed to properly document the work performed. Getting set up with our pharmacy is quite simple. First, a few account forms can be filled out online to provide credentials for your providers and to provide us with shipping and billing information for the practice. We also have the ability to prescribe electronically, and we have agent forms if someone in the office will need to be authorized to submit patient prescriptions for immunotherapy on behalf of the physician. Our account managers will provide step-by-step e-prescribing tutorials and will walk you through getting set up on our portal. Finally, you will need to purchase your allergy testing supplies. Everything ships direct from the manufacturer, and it is good to have your supplies available prior to any training you'd like to schedule, either virtual or on-site. The majority of practices that work with us make use of our full on-site training. This is where we come in and work directly with your providers and staff to make sure everyone is fully versed on the patient workflow and protocols. During training, we provide hands-on demonstrations on how to perform an allergy skin test, how to read and interpret the test results, and how to order, mix, and administer the allergy shots. An on-site training for practices that are new to allergy typically takes a full day. Some practices who have experience with allergy testing or treatment may only need a half day to learn some specifics about our program. We also offer virtual learning opportunities, as well as recorded modules on the primary patient procedures like skin testing and vial mixing. These work well for practices with new staff who need to get up to speed quickly, or when an office has had to pause their allergy services for a while and now need a refresher course. We also provide a comprehensive training manual that contains detailed instructions along with other helpful information and tips. And we make this available in both hard copy as well as PDF. So let's look specifically at the basic workflow for an allergy patient. The blue steps on the left side of the slide show the basic steps in the process, starting with a history and exam with the provider. Next is a scheduled in-office skin test, followed by ordering and preparation of the allergy immunotherapy vials, and finally, the administration of the injections. The green boxes in the middle show the forms and documents that are required and provided by us. There may be additional patient intake and consent forms depending on different practice or patient situations. On the right, in the orange boxes, are the CPT codes that are associated with each step. Beyond the typical E&M codes for a medical consult, there are 3 allergy-specific CPT codes. 95004 covers the skin test. 95165 is for the preparation of immunotherapy vials for the patient. And codes 95115 or 95117 are the allergy injections that are given in the office, and each code depends on the number of shots administered at each visit. A somewhat overlooked element of an ancillary program like allergy is how to effectively identify patients who might benefit from a skin test and/or immunotherapy. Some of our most successful practices utilize pre-screening questions in their initial patient intake paperwork. A simple set of 2 or 3 questions that inquire about a patient's allergies or desire to be tested can often uncover candidates for a full allergy evaluation. Likewise, a number of different marketing tactics can help drive patient awareness and interest in your new allergy program. A couple of important points here are: 1, develop a good pre-screen tool and make this a standard practice for the office. And 2, make sure everyone in the office knows how to answer direct questions from the patient. The most common questions are usually about the procedures themselves or cost. For example, how long does a skin test take? How often do I have to come into the office for shots? Will my insurance cover this? Or how much does this all cost? Having a well-versed staff on the basics of your allergy program will go a long way. Before we are able to perform a skin test or provide any treatment, your provider will need to meet with the patient to take a medical history specific to allergy and then perform an exam. We have a standard questionnaire that asks questions about a patient's allergy symptoms, including time of year, duration, and severity. It also asks about their living and working environment. A discussion with the provider may also uncover other clues about the patient's possible allergen exposures or areas of their life that may be impacted by an allergy, like trouble sleeping or daytime fatigue or recurring headaches. All of these should prompt additional questions and may help justify ordering a skin test. The key is to connect possible allergen exposures with symptoms, though this may not always be obvious. Therefore, skin testing can also be effectively used to help rule out a possible allergen sensitivity. In either case, a thorough history and exam are almost always prerequisites before a skin or blood test can be covered by insurance. A skin test is typically scheduled for 7 or more days after the initial medical visit. This allows time for patients to discontinue any medications that might interfere with the test, specifically antihistamines, which should be withheld for at least 5 days. An order for a skin test should have an assigned diagnosis code along with the medical notes. The diagnosis code may change upon receiving the results of the test, so just keep that in mind. The test itself is a fairly simple procedure that takes about 30 minutes. Test results are recorded as a measured reaction to the allergen after being applied to the superficial layer of the skin, usually on the underside of the forearm or on the back. The reactions are often the size of a mosquito bite, but some patients react a little more aggressively. We provide a standard recording form to capture the reaction measurements. During training, we provide a hands-on demonstration of how to perform the test and how to read the results. Most of our practices will run a verification of benefits for both skin testing and immunotherapy prior to scheduling the test, so this can all be communicated to the patient. After a patient has been confirmed with allergies and one or more allergens are identified as reactive, a discussion about treatment can be had with the patient. As long as a patient's medical history of exposure and symptoms shows general agreement with the results of a skin or blood test, the patient will qualify for immunotherapy. Some insurance payers may require additional notes detailing other treatment options that have failed, like a period of time on antihistamines or corticosteroids that haven't offered optimal relief. In some cases, there may be allergens that are particularly bothersome or simply cannot be avoided or managed by medication. This is common for people with occupational exposures, like those working with animals or someone who works primarily outdoors. For the provider, it is important to be aware of certain contraindications of allergy immunotherapy. The most common of these are patients who are on beta blockers and those with severe or uncontrolled asthma. Both of these situations put the patient at higher risk should an allergy injection trigger a severe reaction. Other contraindications include pregnancy and certain health conditions that might cause complications should a patient experience a severe reaction following an allergy shot. An important consideration from the patient's perspective is whether to opt for allergy shots or allergy drops. Both of these formulation options use the same FDA-licensed allergenic extracts, but only one, the subcutaneous immunotherapy, or SCIT, is covered by insurance. The sublingual immunotherapy, or SLIT, is not described as a route of administration in the package labeling for the allergens. It is therefore considered an off-label use of the drug and would be an out-of-pocket for most patients. So the primary patient concerns are typically dealing with cost and convenience. The injections are likely covered by insurance, but will require the patient to visit the office at least weekly during the first year of treatment. And each visit requires a 30-minute wait period after the injection for those rare cases when a severe reaction might occur. The SLIT drops can be taken by the patient at home, since this treatment often carries a much lower risk of severe allergic reactions. However, again, the allergy drops are typically a cash pay option. Some practices have begun to allow patients to take their SCIT vials home and self-administer the injections. While this is not widely recommended, there are certain patient situations where this may be preferable, and there are extra precautions that should be followed, like prescribing an epinephrine autoinjector and training on how to manage reactions at home should they occur. The preparation and administration of the SCIT injections has a few steps. First, a written order for immunotherapy must be documented in the patient's medical record, along with a proper diagnosis code. Again, the specific J codes may change after the results of a skin or blood test are confirmed. After receiving a prescription, the pharmacy will formulate the patient's allergen mix and ship a treatment kit to the practice. The practice is responsible for preparing the dilutions of that mix following sterile compounding guidelines and filling out the required forms to document the work. The patient can then be contacted to schedule their injections. Most patients follow a weekly buildup schedule for the initial phase of treatment, followed by less frequent visits during subsequent years of maintenance therapy. Some of the more critical aspects of allergy immunotherapy that is administered in the office include patient education and documentation. The patient should understand that allergy immunotherapy is a marathon, not a sprint, and it is important that the patient is willing to stick with their treatment plan to achieve the best benefits. Also, the risks should be carefully explained, including the potential for severe reactions that might require aggressive medical treatment. Finally, the practice must keep meticulous records to ensure that the insurance payers reimburse for all of the work that is performed. When communicating to patients the requirements of SCIT and SLIT, it is helpful to know the basic phases of treatment. For SCIT, the buildup phase typically takes about 10 to 12 months if a patient visits the office weekly. If they are able to come in twice per week, then the maintenance can be reached in half the time. After reaching their maintenance dose, the patient can begin tapering out the frequency of injections. A monthly maintenance schedule is most common, but some patients find that weekly or biweekly maintenance injections provide better ongoing symptom relief. For the slit drops, the buildup phase is much shorter, only 30 days, and maintenance therapy consists of 5 drops applied under the tongue every day. In both options, the recommended total duration of treatment is 3 to 5 years, but the decision of when to try discontinuing the treatment is a discussion that should be had between the patient and provider. One of the more common questions patients will ask is, when will I feel better? This answer is not always straightforward and usually depends on which specific allergens cause each patient their worst problems. For seasonal allergens, treatment should be continued for at least a few months before improvements can be recognized. So depending on the time of year when immunotherapy is started, it may take another year or more to notice significant changes, usually during a peak pollen season. For allergens that have year-round exposure, symptom improvement may be seen much sooner, possibly in just a few months, and even before reaching maintenance. In both cases, the best outcomes are achieved when the patient is as adherent as possible to the immunotherapy schedule. Unfortunately, we do not have specific biomarkers to tell us when immunotherapy has worked or when treatment can be stopped. Usually, the patient must report their overall improvement in symptoms and hopefully a decrease in the medication used to control those symptoms. Some patients may report only modest gains, but there may be certain quality of life measures that can be more telling, like the ability to play certain sports during the spring or fall, or improve sleep or concentration in work or school. A final note should be made about practice responsibilities and ongoing training, oversight, and supervision. The first is related to the mixing of skip vials in the office, which should follow guidelines under USP Chapter 797 that describes how to avoid microbial contamination of the treatment vials during mixing. The second oversight task is related to the training of staff and practice for the preparedness of anaphylaxis. The provider in charge should ensure that every person working in the office understand the general risks of offering allergy immunotherapy and the basic safety measures taken to protect the patient, including when and how to administer epi and when to call 911 should a severe reaction become unmanageable. We recommend that each practice develop a standard operating procedure, or SOP, and document any staff training that occurs for both allergy mixing and anaphylaxis preparedness. There are a number of factors that contribute to practice and patient success with allergy testing in a treatment program. Among these are obviously patient volume, payer mix, and direct-to-patient marketing. But some of the more critical success factors that we've seen include the following. 1, have one or more staff who will dedicate their time to learning the program and be willing to continue training others. They should be a program champion and be able to encourage the patients throughout the course of their allergy treatment. 2, make full use of our practice training and ongoing clinical support. Both will be invaluable for making sure your practice has all of the information to provide a high level of care for your patients. And 3, finally, practices that learn quickly how to weave this program into their existing patient workflow are often the most successful. The key is to just get started and commit to figuring some of the minor details as you go along. Thank you again for attending our presentation on practice implementation of allergy testing and immunotherapy. If you have any questions or would like to receive additional information about our program options, please call or email the pharmacy directly. Thanks.